Well, welcome everybody. It's nice to see everyone as always. So Aruj Kamal is going to be moderating today. I'm going to kind of do the introduction, then Aruj Kamal is going to moderate, and I'll introduce her in a minute. So our title, the topic for today is how access programs can interface and create synergy with direct perinatal mental health services. So basically what we're going to talk about, this came up in the last meeting and in a couple of meetings just around how when we have perinatal mental health clinics, we're providing direct services, then we have an access program. The flow in between those can get super tricky, but they also can become a potential to, it can be tricky, but to help increase the utilization for your services. So that's for all of our access programs. That's what we're going to be talking about today. And just to remind us from housekeeping, if you're not speaking, please keep yourself muted. We are recording the meeting, as you saw, and any please, you can send Dee any messages with any technical difficulties. And a reminder about a couple of upcoming network activities. So we are continuing our monthly convenings on the second Tuesday. Our next meeting on November 9th will be one of our program exchanges. That's the 2-hour longer meeting that sort of is in place of the summits that we still have summits, but we're having them once a year now, and instead of doing these 2-hour long meetings. And we're going to be talking about new initiatives. So really, this will be an opportunity for all of our programs to share about new initiatives that we had. This came out of a request for people to sort of share new initiatives, innovative things, so we can all learn from each other. So please, if you have a new initiative or something that you're particularly proud of that you want to be sharing, please let us know. And we'll be happy for people to present at that. So please let us know. You can either enter it into the chat or send a direct message to Dee or Melissa or Josephine. And the next meeting after that will be December 14th. The topic is to be decided. And next slide, please. And then our virtual summit will be, we're now doing these once a year, as you remember, and the next one will be March 2nd and 3rd. We're still deciding on the topic for this. It'll be 12 to 4:30 on March 2nd and 3rd. And we're very excited. I don't know if I didn't see whether Wendy joined yet, but we always have usually people from PSI here. And really excited to share that we sent an email about
this. I'm here. This is Chris. I would love to share.
Oh, please do.
About the maternal mental health hotline. PSI was awarded the contract. For this, it'll be a 24-hour, 7-day-a-week, 364-day hotline that will be answered within 5 minutes. We hope to be launching in 2022, hopefully sometime February, it's the end of January, 1st of February. We're very excited about it. We're really, really honored and happy to be partnering with HRSA and being the convener of this hotline. We're very excited. Oh, I see Wendy's in the chat.
Yeah, and we're excited about it. I mean, this is a long time in the making, so I think we're all excited because it's sort of like now we have the access programs, the capacity building providers, and then there's direct line with for patients to call, and there's no better place, no one better to be convening it and to be recipient of the contract than PSI. So we're very excited for you. Congratulations, and we definitely there's more topics to come on this, but I think there'll be. We're excited to also think about the synergy we can create between the hotline and the access programs. And yes. So, more to come on that. I'm sure we'll be talking with you about that, Chris, Wendy, and the team at PSI, but wanted to announce it here. It's just really exciting. Congratulations. We're all very excited for you and for
everybody, for all of us.
Right.
It's a huge win for all of us. So we're very happy to be a part of that.
Yeah, it is. And thanks to all the advocates who helped get that legislation through to get it into the budget. And we usually have advocates here, so thank you to all the advocates as well. It's very exciting. Next slide, please. So I'm excited to introduce, probably a lot of you know Aruj because she presented at a meeting or two ago. And so Aruj is a perinatal psychiatrist who's at UMass. I've been working with Aruj for a very long time, since she was a resident. And she's now the director of our women's mental health outpatient clinic at UMass. She's also part of our Lifeline for Moms team. She's one of our perinatal psychiatrists at MCPAP for Moms, and is also part of our network team. So Aruj will be moderating today. I'm very excited to introduce her, and I'm going to pass it off to you, Aruj. Thank you.
Hi, everyone. My name is Aruj Haider. For those of you who may not be entirely familiar with my face, And as Nancy said, I am based out of UMass Memorial. I do some work with MPAP and Lifelines, and I direct the Women's Mental Health Clinic. And I am very much looking forward to today's topic and hearing what our three discussants have to say. So first, I would like to introduce Dr. Amrita Bhatt from Pal for Moms at the University of Washington. Second will be Dr. Mary Claire Kimmel she's the medical director at NC Maternal Mental Health Matters program at UNC. And then our third panelist will be Dr. Christina Wickman, who is medical director at the Periscope project from the Medical College of Wisconsin. So
Thank you.
Bhatt, go ahead.
Thank you. Hi, everyone. I'm Amrita Bhatt. I'm a perinatal psychiatrist at the University of Washington in Seattle. And happy to be here to discuss how our perinatal psychiatry consultation line interacts with our clinical services. Next slide, please. And you can just click through the clicks on the slide. This is basically describing the structure of our consultation line, which is similar to the standard structure, which is 9 to 5, non-holiday weekdays. Any provider in Washington state who has questions about perinatal mental health or substance use disorders can call, and they are connected directly to a UW perinatal psychiatrist most times. If they're not connected, we return their call within 1 business day, and we send an email summarizing our discussion after the telephone consultation. And our line is funded by the Washington State Healthcare Authority. Next slide, please. Here is our lovely team of perinatal psychiatrists and our wonderful admin team as well. Next slide. And I wanted to just kind of contextualize our perinatal psychiatry consultation line within our larger maternal child mental health program. Our vision is that all people with childbearing related mental health and substance use concerns will receive effective, equitable, and culturally appropriate care. And our mission is to transform perinatal mental health and substance use disorder delivery systems through excellence in clinical consultation, education, and health services research. So those really are the 3 arms of our program: clinical consultation, education, and research. Next slide, please. So our direct clinical services that we have, of course, are our consultation line. We have a co-located specialty mental health clinic within our high-risk obstetric clinic, in which a perinatal psychiatrist, actually a psychiatrist dually trained in perinatal psychiatrist and addiction psychiatry, and residents are available to see patients who come in for their high-risk OB prenatal visits. And we also have a perinatal psychiatry clinic within the outpatient psychiatry clinic and our newly launched telepsychiatry clinic. In terms of our training programs, we have our monthly video conferenced MAP Echo series, which is a 60-minute long lunchtime short didactic discussion followed by a case discussion with community members across Washington state. And these are usually pediatric providers, obstetric providers. We have social workers, nurses, anyone who takes care of perinatal people. We also provide ad hoc statewide trainings for frontline providers. We recently launched a Women's Mental Health Fellowship. We are in our 2nd year of this fellowship, and we provide psychiatry resident training, for example, a selective in their 2nd year, and then the clinical rotations in the 3rd and 4th year. We also have our research programs. So, all of our programs do intersect with the perinatal psychiatry consultation line to some extent. For example, our women's mental health fellow might answer some calls under supervision, or a MAP Echo participant might call the Pal for Moms line if they have a more urgent patient-related question. But for today, I'll just focus on how our telepsychiatry clinic interacts with Pal for Moms, or our perinatal psychiatry consultation line. Next slide, please. Here's just a timeline. So as some of you know, we started small in 2016 with a private funder, and we were just open 2 hours on weekdays. And then in January 2019, the state began to fund our service. And since July 2019, we've expanded our operating hours to weekdays from 9 to 5. We added the virtual perinatal psychiatry clinic in May 2020. Next slide, please. So here's just our PAL for Moms call workflow, which is, I think, similar to the workflow that many of you have, which is that a call is answered by our perinatal mental health navigator, Alicia. On an average of 78% of the times, they're directly connected to the psychiatrist, and then we have the consultation call and send a note by the next morning. Next slide. And when we began, we didn't have any telepsychiatry offerings, but in response to COVID-19 in May of 2020, we, with private donor funding from the Perigi Fund, we began to offer in-the-home telepsychiatry assessments. And this was not initially started just with regard to PAL for Moms. We, in fact, wanted to reach across Washington state. We wanted to be able to reach clients who are served by home visiting programs, those who are served by FQHCs. So we opened it up in this way, and any referring provider could fill out an intake form. They would reach a navigator for the telepsychiatry clinic, and then the patient would be scheduled for an assessment. Next slide, please. So with regard to PAL for Moms, in addition to all of these direct referrals that we were able to open up for across the state, now if we have a PAL for Moms call that the perinatal psychiatrist felt would benefit from a one-time consult, or the caller was actually requesting a one-time consult, we would send the information on how to refer the patient to the virtual clinic to the caller. The caller would then follow the usual workflow for the virtual clinic, which is filling out the online referral form and then being registered and scheduled by the telepsychiatry clinic navigator, followed by the telemedicine assessment and recommendations. And there's some workflow things which we're still working out. For example, our PAL for Moms recommendations do not go in our electronic health record because patients are not necessarily patients of University of Washington that the caller calls about. So our PAL for Moms navigator will take the PAL for Moms recommendations and upload them into the EHR if the patient is receiving virtual consultation. So that's an example of how we're kind of merging the workflows of the two services. Next slide, I think that's the last slide. Yeah, so that's just a brief overview of our clinical service and how it interacts with PAL for Moms, and I'm happy to take questions.
Great. So that sounded very interesting, Dr. Bhatt. Thank you. If I'm thinking maybe we can save questions after the other two panelists speak, if that's okay with everyone. And so we can leave, a live Q&A at the end for more questions to come in, just to make sure we get through all the discussions. So Dee, maybe we can bring up the next discussants. Great, so Dr. Kimmel will be next.
So we really appreciate being able to speak today about how we have been creating NC Matters integrated within our system. And so we're gonna, let me make that slideshow. Okay. So this first slide, so I think this was really the foundation for perinatal psychiatry and at UNC that actually it's great that Chris is here today and that Chris Rains and Samantha Meltzer-Brody really developed this amazing relationship with OB and were able to make these connections. And so Chris worked very closely with the OB team to create an algorithm to really get them. In fact, prior to this, there's actually one paper I sometimes present showed just kind of how limited screening was. And so this, I think, really got them to feel comfortable screening, got them to feel comfortable talking about mental health. And so you can see the algorithm that they created, based on screening, and then kind of what to do next. What are the things that they can do? And then obviously feeling like they were being backed up, and which I think is key. And so given this, and because of this, we've been able to really grow the program at UNC. I mean, this really was the foundation to creating, we now have 2 resident clinics. We have a provider who is out at another hospital in Raleigh and has a very close relationship with them. We have, and our perinatal psychiatry inpatient unit. So I think all of those things really came out of this relationship and building this algorithm. So, now where does Matters fit in? And I think really our goal originally was to think about too, we're meeting the needs of patients within the UNC system, but how do we now really move out into meeting the needs of patients that are being seen elsewhere, particularly in our rural counties. And so this was my first attempt at an algorithm. And actually I did this with my other co-director of the perinatal psychiatry program, Crystal Schiller. And so she is a psychologist and she really heads up our psychotherapy services. So that's one of the other things that we're really fortunate to have is that we have several psychologists, several LCSWs who see patients. And so, and actually we have a grant, the Summit program that is testing actually a mental health specialist versus an OB nurse providing behavioral activation therapy. So that was really also a way that we're really trying to extend the amount of services and get access for more people. And so this was an algorithm to, so, and then also I think very sad for the OB team was Chris's retirement. And so I'm really thinking about like, what is the next, like, how do we kind of meet these needs and no one could possibly fill her shoes. So how do we get patients, continue to get them connected to services, and who are the right patients to get connected to services with us? So I think some of the challenges were that they were really comfortable with getting patients to us. And one thing we actually found is all the surrounding counties around us were already referring to UNC and then also to Duke, our other partner. And so for the most part, patients were getting connected to us, at least from the central part of the state. And actually, but we've also now been really connecting with the western and eastern parts of our state as well. But so they were already making that. And so now it's a bit of a shift of how do we get you to help us to continue to work together as a team? And so as opposed to kind of a referral system, how do we provide bridging in the meantime? Our wait lists have gotten longer, particularly with the pandemic. And then as different staff people had to be in and out for various reasons. And so we really have been trying to message to people, and I think that's a change in their thinking, is that we are going to walk alongside you, but we're not necessarily going to take your patient right away. And that we are figuring out who are the right patients who want to stay within your care, who are the patients who need to come to psychiatric care, who are the patients that we need to connect with the community, who are the patients that need to go to maybe even higher level of care, like an ACT team or something like that. And so we've been, and how do we help kind of make them feel like they're not alone, particularly in that period, kind of the bridging period. And then that's where our telepsychiatry really comes in, as we have been doing more and more assessments. And then those assessments are really that kind of first step in, we are going to walk alongside you as we are figuring out the next steps for this patient. Especially in those cases where it's clear that it is more complex than something we can kind of coach you to do in the phone call, and even in multiple phone calls if needed. And so that just kind of, again, highlights, I think, some of the challenges that are listed here. We've seen an increase in the need. We've had some staff who've been in and out for various different reasons. And I think getting people to understand that this actually isn't more time, and that in the long run, we are still going to, we're not expecting them to take care of the really complex patient with serious mental illness. We're not expecting that, but we are expecting and know that that patient is going to continue to get their care with the OB team, and that we want to walk alongside with them, and that it may be difficult to get that patient into another level of care due to many different barriers, particularly in the postpartum period. And so we are going to continue to work together to figure that out. And I think that's also one of the things that we feel we're looking at. How can we, as we now kind of really have our consult line going, we're doing a lot of calls, and more people are calling. We're also thinking about what is the behavioral health navigation piece that we need to grow. And so some of the solutions that we have in terms of working within our integrated system is we've worked closely with the scheduling team for the psychiatry department. Especially, I think there's always been kind of periods of time where they felt very, very stressed when there was not availability. Particularly at those times, like when the resident clinic is switching over, those kinds of key periods are times that it continually was a period where there was a longer waiting list. And so we've worked closely with them to help them talk with people, help them understand that we aren't necessarily saying that they're not going to get into care in psychiatry, but that we're here to help, and that that's what the Matters team is there to support them. And so we've been working closely with them. And really working on this messaging around bridging, and sometimes that bridging actually leads to the patient continuing to get their care in the OB, kind of as we figure that out together, but really helping them build the confidence that and also feeling like we're not just putting it all back on them. And we've seen that with, I think, the calls we're getting. And actually one of the fun things is we also are getting more and more calls from psychiatry in the region. And so we're doing a lot more kind of just colleagues wanting to talk about cases, which I think is great. And I think one of the keys was, we've had great support from maternal fetal medicine, from the psychiatric leadership at UNC, and from the state, and then from our partners at Duke. And so this is our algorithm now, which actually, as you can tell, is actually very similar in a lot of ways. I think in the end, we have to kind of have, simple messaging around, you have someone to call, don't worry. And so our messaging has been, repeatedly kind of call matters. We can help do assessments. We can kind of help you do some planning. We can help you with medication questions, really kind of, but we can do all those things, but, just really call us and we'll figure it out with you. So, and with your team, depending on who has the time to call. And that's it.
Thank you, Dr. Kimmel. Any questions for Dr. Kimmel before we proceed to the last panelist? And again, we'll have an open Q&A at the end, but if anyone wanted to step in and ask something, please feel free to do so. Okay, so Dee and Josephine, we can go to Dr. Christina Wickman from the Periscope project.
All right. Hello, everybody. So it's so interesting to hear the other two presenters and the algorithms and how they've chosen to really integrate their access programs with their clinics, because we've taken a very different approach and we've tried to keep them as separate as possible, recognizing that there's overlap, but we've really tried to have pretty tight boundaries between the Periscope project and the perinatal psychiatry clinic, of which I'm the medical director of. So on the left side, we've got Medical College of Wisconsin Department of Psychiatry, which is where the Periscope project is housed. But from our inception, we were statewide, and we recognized that there was going to be a whole lot of blurred. And so we tried to keep that very succinct and separate from the clinical face-to-face work pre-COVID that I was doing in the co-located department of OBGYN. What has made this very difficult over the last 4 years is that I'm the medical director and primary responding psychiatrist for the Periscope project. But I'm also the medical director and primary and only attending psychiatrist in the perinatal psychiatric clinic. And so because it had the opportunity to be fuzzy, we've tried to really keep that as separate as we could, paying really strong attention to verbiage, meaning when we're talking about these two separate programs, we utilize the Periscope project and not Wickman, or we utilize the perinatal psychiatry clinic and not Wickman or Kruper as our psychologists, but really utilizing the names of the programs and not interchangeably, primarily with my name. Is what happened in the early days, is that Periscope was associated with me and associated with clinic, and it got really fuzzy. And so we realized that right away. And because Periscope was not provided by funding from MCW, it was only housed within MCW, we wanted to try to keep things as separate and with tight boundaries as possible. So over on the clinical side of things, so that's housed within OBGYN, and we've got this perinatal psych or women's mental health clinic. Myself as a psychiatrist, Dr. Kruper is our psychologist. We have trainees under us, but the process of referral for that has not changed at all, even though we've had the development of the Periscope project in the last 4 years. That has remained a very separate entity as to how you get referred into that program. And so with that, how they are a bit connected is the referral for Periscope for community resource information. And so one of the pieces that we obviously provide to our callers is information about community resources across the state, of which perinatal psychiatry is one of them. So if a caller we calls and we do a consultation, and I recommend, man, this person could really benefit from a face-to-face consultation, because that is not a service that Periscope provides, I would circle back and allow our triage coordinator, if they haven't already, provide that provider with a list of perinatal psychiatrists in our area that could provide that face-to-face consultation. Now, you've heard me talk before, Wisconsin doesn't have a whole lot of perinatal psychiatrists. And so inevitably, my clinic was one of the ones on that list. However, we did not provide, there isn't a warm handoff, there isn't anything that is being treated any differently if a consult referral is coming from Periscope versus a self-referral in the community versus a referral from one of our docs in our OB clinic. The patient still needs to go through that exact same process regardless of how they got the information for that clinic. So we've really been quite cautious about not having warm handoffs, because inevitably what was happening in the very early days is that providers from across the city and across the state would call Periscope and say, I want to get into Wickman's clinic. Not happening. Like, that's not how this service works. We've tried to really separate it so that there are no favors for just utilizing our line. That's not going to give you easier access into the clinic. The same boundaries and same criteria need to be met regardless of where that patient is getting a referral or information about that clinic. That is what our lessons have been learned for the last couple of years. And I'm happy to answer questions too, because again, it does seem very different than what other programs have done. So.
Thank you, Dr. Wickman. So I'm going to read out, so that those were all wonderful. Thank you to all the panelists. We do have one question, so we can start with that. So Jim Beasley, a question I have for all speakers is whether BH staff working at your center's practice system can call your line for resource referral support for those patients needing a different level of service not provided internally. If so, do you count that as call encounter? Okay, so does that make sense to everyone?
Yeah, I think, I mean, we have taken the view that we will help we are providing support to any provider who calls. And we have had cases like this where we're helping people navigate navigate to other services as well. And I think actually the one that makes the most sense, and we're still working on kind of the algorithms. In fact, Karen and I just had a meeting talking more about the algorithms for substance use and liaison with our state. We have a state line to help people get connected to, for example, to MAT and so perinatal patients. And so kind of thinking about how we connect people, even within our own system, sometimes we do end up helping kind of think about, and particularly as we're building our connections with other resources around the state, thinking about connecting people with other resources. So.
Yeah, and that's a great question. I'm happy to talk about that in terms of what we do at UMass. So I direct the Women's Mental Health Clinic at UMass, and that comes up a lot, whether it's BH staff or patients calling through and saying, what exactly do I do with this patient or this referral? Where exactly do they go? So we have kind of established that our fallback, or kind of our basic model for referral, is to refer the patient or the caller back to the OB and have the OB call MCPAP for Moms. And that's been really helpful, because MCPAP for Moms, not only do they help with research and referral, but the initial intake can really help triage where that patient goes. And while I work in MCPAP for Moms, I'm also in the clinic. And once that initial intake is done, I can kind of triage and say, oh, yeah, no, that's MCPAP for Moms. And any of the other perinatal psychiatrists at MCPAP for Moms can give me a call and say, I think this needs, a different level of care or more short-term follow through in the Women's Mental Health Clinic. Most of the patients that will come to me after they've been triaged in MCPAP for Moms, and one of our perinatal psychiatrists is aware of them, they tend to need more short-term management, but it's really helpful to have that initial, triage system based on MCPAP to decide where that goes.
Yeah, and I think just to connect it a little bit, like, thanks, Aruj. I totally agree. And I think what Christina was saying is we've kept it pretty separate too, because similar, like when we started, like I was doing the co-located clinic and I was directing MCPAP for Moms, and we didn't want it to be like a back door to like get it, because we didn't have the capacity. If we had the capacity to see everybody, we wouldn't need the access program in the first place, right? So like even now, even though like Aruj, like if I see a patient, I'll refer them to you, right? Like people calling, I don't like tell them like, oh, I'll call Aruj and see if we can, like we kind of say, oh, let's see if we can get them in. We'll see if there's outpatient psychiatry. Let's start with a face-to-face, but we kind of don't, that's all internal. We don't tell people that because like, we don't want them to be like calling MCPAP to get in. So we say, oh, we'll refer to outpatient psych. If it's someone from UMass, they do know it's the clinic, but we kind of say it like, we'll do a consult. And it's a little bit, we don't really advertise that to them. I think it's similar to what Christina does, because it's similar. We want to keep it separate. And part of that's because of because it is a lot of the same folks, just to build on what you're saying.
Yeah. That conversation with me and the other perinatal psychiatrists, I should have emphasized, is definitely internal, but it definitely helps to know that, that support is there. But externally, I do think we adopt a similar approach to, Wisconsin and what Dr. Wickman does in terms of, keeping that separation. And it's so crucial because, as we know, there is a dearth of, perinatal providers. So that I think so far that model has helped us as well.
Mm-hmm. Yeah.
And I think the way, if I can add, that Washington State is a little different is we have our perinatal psychiatry clinic, which, pre-COVID was in person and now is in person and tele. And the way that clinic is set up, we're not able to see patients that aren't already registered within the UW system. So that wasn't really an option for us. Even if a PAL for Moms caller needed a one-time face-to-face assessment, that was never an option. So only after we added the virtual clinic in May last year, we've been able to provide one-time assessments for callers to PAL for Moms. And that telepsychiatry clinic is separate from PAL for Moms because the funding is different. And we also want it to be available to others who don't necessarily need to call PAL for Moms, but want to refer the patients directly.
So Dr. Bott, out of curiosity, so the virtual perinatal psychiatry clinic, What type of model is that? Is that a one-time consultative model? You had said, there are certain types of patients that do go there. Is it short-term management? It can be either or at UMass, but I imagine you really tailor it to the patient's needs. So what's the flow like in that clinic?
The virtual clinic is meant as a consultation clinic, one time, maybe 2 times if we need to complete the assessment. Our perinatal psychiatry clinic can be short-term management as well, but the virtual clinic is meant to be a consultation clinic because we don't want to become a bottleneck.
Right.
And we want to be available for people as they need assessments. And then so we always do a warm handoff to the referring provider. And if there's medication involved and the referring provider is not a prescriber, say it's a home visiting nurse, then we'll make a warm handoff after our assessment, both to the referring provider and to either a primary care provider or an OB. There have been a couple of times when there has been no prescriber, and then we've had to support the referring nurse, for example, in connecting their client with a PCP so that we could, again, make that connection.
Yeah. And that's definitely something I, when I first took on this role, learned the hard way to establish beforehand, is there a referring provider? Because once you see the patient, where exactly are those recommendations going to go? So it can be tough because now we're getting so many different types of people calling in, and not everyone can necessarily prescribe. And while we may want to see them all, those boundaries can be tough, but are very important, as you're saying. So. See. Any other questions? Go ahead. I
was just going to ask Amrita your question. So it sounds like, because for a MCPAP for moms, we see the consultation as part of our services. But for you, if I'm understanding correctly, UW, or PAL for moms, I should say, does a telephone consultation, and you're referring them to a separate service, which is really separate. You're not seeing the virtual clinic, or maybe you are. Are you seeing that as part of PAL for moms, or is it? Because for us, it's we do one-time consults in the Women's Mental Health Clinic, but we see that's totally different in MCPAP for moms. We do them as part of MCPAP for moms, and then maybe they'll go to the other clinic. So I'm a little bit curious about that. If you see that as part of PAL for moms, or maybe it's totally separate and you refer to it.
So the way it's evolved is it started completely separate, right? So we spent the first 4 to 5 years of PAL for moms without the option of doing an assessment. And so we became kind of adept at giving recommendations, even if we said, well, that would be so good if we could do a one-time assessment, but we didn't have that option. And so we were providing recommendations on the consultation line. And then the virtual clinic started completely separately, not necessarily just to help with the PAL for moms consultations, but as to be available across the state in response to the pandemic. And so it's slowly being utilized more when we find a need within a PAL for moms call for that one-time consult. So it is separate, but I think they are, there's a lot of overlap.
Thanks, that's helpful, thanks.
So Jim, do you have any best practices about how best to re-educate providers from calling your center versus calling the line? That's a great question. And I'm curious to hear what the panelists have to say first, and of course can offer how we help navigate that at UMass. But that's a great question.
So I can talk a little bit about this again, because it was a one-person show for so many years. The first several months that we launched Periscope, we also didn't want to make it more burdensome from the docs that I was literally working across the hallway with, that had access to me all the time for these literal hallway conversations, or would pick up the phone and call me or page me or whatever the case may be. And so for the first several months, it was lots of redirection, but I also never said, don't call me. We did lots of marketing and told them about Periscope and how I'm going to be able to pick up the phone faster and be more responsive with Periscope versus maybe a text message or whatever the case was to my personal email, my personal cell phone. But we compensated for that in the first several. We have a radio button on our red cap that said consulted psychiatrist directly, because we knew we're going to have to educate, especially my right in the medical college docs, kind of what Shelby always called our low-hanging fruit, the docs who worked with me and would utilize our service. But it took several months to educate them and to get them away from calling me directly versus calling the 1-800 number. And it's worked, but it's just taken a lot of redirection, a lot of, love and compassion, right, over the years to say, hey guys, remember, sometimes I want to take a vacation, call the 1-800 number. And they're better about it these days. It's pretty rare. Like if you look at the percentage of the number of docs that call me directly now versus in year 1 or even the first 6 months, it's much, 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 much lower. And it was primarily our Frederick Medical College docs where I'm obviously faculty. So if you've got the opportunity to kind of have a little bit of wiggle and document that within your data, then you can also see how that can change over time too.
Yeah, we've definitely seen change with that too. I know we used to get a lot of messages directly either to myself or to one of our nurse practitioners, Susan Myers, would get a lot of messages directly. And we've done a lot of work to also include Karen and Burns, our program manager, and Carolina Alford, our our behavioral health coordinator, and really kind of help them think through like what is the best place for this patient to get care. And and yes, we can, and part of that has also been because we have kind of said as an institution, like we want to make sure UNC patients can be seen within the UNC system if possible. And that's true for our therapists too, especially. And so we've had to kind of work this relationship where we didn't want the messaging to be, don't call either, only call matters, don't call, because then the therapists were like, well, we still want, we're still here, but we also can only really meet the needs of, the patients within our system. And so there's been a lot of just kind of, I think along the way messaging, like we'll get the patient to the right place, but work with us. And we're really, and when we're saying this is a matters call, it's not that we're saying we're not going to help you. We're saying that we think that this patient could be better served in another way. And we're going to help figure that out through matters.
Yeah, no, I think that's a very important point in terms of prioritizing the patient's care. I think once the tone of the discussion is changed to we're going to get the patient where the patient needs to be, in the most efficient way possible. I notice on the other end, they're kind of at ease and they say, oh, okay, we got it. I do agree when a perinatal psychiatrist appears in both, venues in terms of access program versus clinic, that's where the boundaries especially are important, as you were saying, Dr. Wickman. And it can be hard because, for example, for patients who, for example, have serious mental illness, if it's a patient that comes through McPath, a part of me in my mind, I'm like, oh, I could easily see them in my clinic, but, boundaries, and we will get this patient in the right place, and, resource and referral will chime in, and we'll hopefully get a psychiatrist for them longitudinally, but in the meantime, let's do this consultation. I'm curious if you all have also struggled with that pull to want to do it, and if so, what are some things you're kind of telling yourself to hold yourself back, and how often do you run into patients where you kind of second guess, oh, could they be seen in this clinic or not?
That happens to me on a pretty regular basis.
Yeah.
And so I think my back way approach to be able to do that is to reinforce and say, hey, my triage coordinator is going to send you resources for perinatal psychiatry. Hint, hint, look at the Frederick and Medical College. I know for a fact they've got availability in the next 2 weeks, as long as the patient's willing to see a resident and calls this number today. Like all the information will be in the email. Reinforce it to your patients so that they can take that next step. And so that has been my backdoor approach of like, hey, I really think this patient does need a face-to-face. I'm happy to help you. I need you to go through this pathway to make it happen, so that I don't pick up the phone myself and call my scheduler myself and say, hey, get this patient in.
Yeah. So Dr. Wickman, out of curiosity, internally, have you ever taken a clinic from, access program to clinic? Does that crossover ever happen? Because it sounds like you're doing a great job with the boundaries.
So where I have actually called our scheduler and like bypassed the referral. Right. No, we made that decision really early on because of the boundary piece. And so It wouldn't be, sometimes it's my scheduler will call me directly and say, hey, or you must have had a Periscope call today about this patient and et cetera. You know, your first available isn't for say 4 weeks. Could you get her in sooner? So that's the backdoor approach then if she were to call me. So if the patient actually takes the initiative, calls and identifies as a Periscope patient, I may say, yeah, put her in earlier. I know the next story. But at least from the patient's perspective and for the referring provider's perspective, there's been some boundary there.
Yeah.
So and it's probably not unsimilar to what you're doing with MidCap for moms. It sounds like definitely. Kind of an internal discussion. Yeah,
definitely.
And similar with Washington State, if we feel that someone needs a one-time assessment, we'll say, we recommend a psychiatric assessment. Here are some resources in your area, in your zip code, and here is the link to the virtual psychiatry assessment that we offer. You know, whichever one happens earlier is the one we would recommend. Because there was a comment in the chat about wait times, and we are seeing long wait times. I think we're booked out 4 or 5 weeks, which is which is unusual and difficult in the past few months.
Wow.
And I think part of that, I mean, if you have one provider in your system that is out for an extended medical leave, that can really change things. And I think that's part of what's been so difficult for people to understand that, even within the community, not in the UNC system, because they were just used to kind of just sending people, but people were, I think, not always getting connected because there is just sort of this ebb and flow. You know, there are times that the therapists are able to take patients and they've got, but then someone goes out and then they're not as able to take. And so we are helping kind of, I see us as also, we've kind of communicated that we're here to help navigate some of that too. And then, and that really was where we started getting so many calls, was because of the pandemic and because all of a sudden things were all very confusing about who could see patients and who could not, and that, particularly when things were first locking down. So I think that's one of the strengths of this, is that you're really helping connect people and also kind of providing, making sure that things aren't falling through even in between times.
I have a question. My name's Ashley. I'm calling from Illinois Diocese. So I'm one of our consultants for there. I'm also one of our for UIC's women's mental health attendings. And I'm just curious from the programs other than MCPAP, like about the one-time consultation, like how that works. That's not something we offer, but there's been times where, if the patient's bipolar or is using benzos or something, it's more complicated. And I feel like I can't be as helpful because the provider hasn't obtained a sufficient amount of information. So I'm just wondering, like, how does that look if they're going through your clinic for a virtual one-time consultation in terms of like EMR, like billing, all of that?
Go ahead, Dr. Bhatt.
Yeah, I can. So if we are seeing them for a one-time assessment in our virtual clinic, our virtual clinic navigator will actually, once a referral is complete, will call the patient and register them as a University of Washington patient, and then they'll be seen within the University of Washington system. And so then they'll have a record within our EMR. But there's no connection between our record in the psychiatry consultation line database and then the EMR. So the psychiatry consult note can be uploaded into the EMR, but we don't yet have a smooth process for the reverse, the EMR note to go to the psychiatry consultants.
So do you just not bill for those and consider that part of your consultation service, or is it?
No, those are, we bill for them as a regular clinical consultation.
Oh, okay.
Yeah,
So
it's not done. It's not.
Oh, sorry. So it has to be someone who's like connected, is identified as a patient, whose insurance you guys take.
Yeah.
In order to provide that.
Yeah, which thankfully we take most insurances, including Medicaid. So we bill it as a regular clinical service. It's not done during the PAL for Moms consultation line. So for example, I staff the PAL for Moms consultation line on Tuesday mornings, but I see patients in the virtual clinic on Monday afternoon. So they're two completely separate activities.
Ours is actually we've gone back and forth about the billing, but we do not bill. And we have, that is part of what our mental health specialists, that is part of what they're supposed to be doing, is doing assessments with their protected time. And so because of that, then we can also see, I mean, we sort of see part of what our role is to see patients that are underinsured or uninsured, and to help kind of navigate what to do in those situations. And so we do put a note in our, this was at the beginning, was always, so we have a red cap to a database that has certain information we collect there from all the calls. And then we actually document everything, all the calls and our assessments, all in either Duke's medical record or our medical record, depending on which provider did it. But we haven't been billing because we talked about it, and even when they have insurance, we didn't want a case where someone would get a copay or something when we were grant funded. So
yeah, that's what I'm wondering, because I have, like, I do so much inpatient now, but like when I'm not an inpatient, I run our women's mental health eval clinic, and we do a lot of like one-time consultations to other psychiatrists and providers, and we just do it as regular, and then we send them back to their provider and do consults like one time. And I was like, oh, this is so great. And just thinking like, are there ways? But we take Medicaid, but we don't take like county care. And like, so it's just confusing. Some insurances will take for inpatient psych, and then we can't help those women as outpatient. And that's also been very frustrating when I can't get that I'm connected to outpatient with a psychiatrist who will adequately treat them too. So okay, thank you. That's helpful.
Yeah, that's a great question. Great question. Thank you for asking. Any other questions? I'm curious for the panelists in terms of the last question and wait times. Has the wait time increased tremendously during the pandemic? I mean, I can see it going either or. At UMass, it's been quite busy, but I'm curious at your institution, and anyone else, feel free to chime in. What's that looking like right now during this never-ending pandemic?
So in Wisconsin, we certainly saw a huge increase earlier. So spring into summer of 2020. And that's continued via Periscope. So we're continuing, our year 3 was higher than our year 2, our year 4 is continuing to grow. Hard to say how much of that was pandemic based versus just continued growth of our service, given that we're pretty young still. On the clinical side of things, I was blessed that I've had a sheer just number of residents who wanted to do electives in perinatal psychiatry the last 2 years. And so because I've had a high number of trainees in clinic, our wait times have not increased, even though our volume has had a bit of a bump up. We've just had, I currently have 4 residents in clinic with me these 6 months, and I've got 4 6 months, which is fantastic. I'm not even taking new patients myself right now because I don't have enough volume for my residents right now, which is a good problem to have.
Yeah.
Don't let that out in the state of Wisconsin. but it's a good problem to have. We can get people in within 1 to 2 weeks pretty easily right now. But I think it's more because of the number of trainees I have currently, and not necessarily because our volume certainly has increased. To clinic too. Yeah.
And it could be a combination of both. I'm experiencing the same thing, Dr. Wickman, especially this summer before I think applications are due. We have a lot of medical students and residents really excited to take on the elective. And, sometimes we'll have up to 4 in one virtual clinic, and it's interesting to navigate. So we can see many more patients, and that, the wait list will temporarily decrease at UMass during the summer when we have more trainees. And then I'm seeing in the fall and winter, it can kind of lengthen again, but, it's kind of like, walking on this fine line. So.
Yeah, I think that's interesting. I mean, there are just so many of these factors of trying to figure out, what the need is. And we've run into that too with our resident clinics. Some years we'll have 2 residents we have 2 clinics and 2 residents in each clinic. And some year we'll have 1, or some years we'll have 3. Yeah. And then of course you're going from a 3-person clinic to a 2-person. And so then there's a backlog there. And so we're kind of always navigating sort of, and so I think it's hard to tell, but I definitely feel like we got a lot of calls of the pandemic because of the stress and things going on. And then as people used our service, they also realized how helpful it was to be able to talk about all sorts of different cases. And so now it's kind of kept continuing, partly also, as Christina was saying, is because the word is getting out and we're so new. But
so Maria, just a follow-up, Maria Music, thank you for the question. Just a follow-up question on perinatal clinic volumes. And I think she's asking, in general, how many patients are the panelists seeing weekly in terms of new evals?
So inclusive of all of my residents, I have the capacity to see 8 new patients a week.
I'm sorry, what did you say?
8, inclusive of all of my resident clinics. We have the capacity to see 8 per week.
I mean, our matters assessments, it varies. I mean, they're definitely, it's been increasing too. I would say, I mean, there was a while there, although I was covering several days because we had multiple people out, but was doing, I think at most, like, I don't know, Karen can probably speak to this more, but I felt like there was a couple, at most I would do like 3. And then there are other weeks where we don't have one. So it's kind of, it varies a bit.
Yeah.
And part of that, again, I think also speaks to kind of, if they're able, kind of where is their ability for people to see people, where is their not ability, on all of that.
Yeah, we similarly do about 4 a week for our virtual clinic. And, oh, sorry, Mary was still saying something, but she's on mute.
Oh, yeah, I was just, what Karen said in the chat was that we can do, I mean, each of our mental health specialists can do 2 a day, but we have yet to get to that.
Mm-hmm.
Yeah. In our perinatal clinic, we'll see 8 to 12 because we have residents and we have more than one attending. In our virtual clinic, we'll do 4 a week.
Wow.
For McPap Rouge, we could do 10 because we have, but we could do 10 evals a week. And what is it in the Women's Mental Health Clinic? Because we have more through McPap than Women's Mental Health Clinic, which is why we tend to do way more through McPap but then it's also through academic medical centers across the state. So it's a little bit of a different thing. But how many in our clinic do you think?
Yeah, it can vary, but we can do up to 4 in 1 week. The most I've done is 4 in 1 week, but it could be 1, 2, it varies.
So we tend to do them we have more capacity through McPap for moms than we do through our clinics. We tend to do it that way, but we have the face-to-face consultation as an option. So,
yeah.
Thank you.
And just being mindful of the time. Yeah. Thank you, Maria, for the question. We should wrap up. Thank you to all the panelists for that wonderful discussion. I hope everyone found it helpful. And any questions, feel free to email us after, and we can definitely follow through and continue this online. Thanks, everyone.
Thanks, Aruj, for moderating. Thanks to the panelists. Thanks, everybody.
Thanks, panelists.
Thank you.
Bye.